I don't know how I missed this. I have no idea how I missed this, and it really doesn't matter, but I switched the chapters around. Like, I should have, the next chapter after blood was the heart, and I started talking about blood vessels. Because to me, it's all the same, to be honest. All three of these chapters are the same. It doesn't really matter what order you present them in, but I reversed it. So I did, so depending on what book you had, I did, I did 19, and then I went to 21. Right. So I'm going to finish 21, blood vessels today, and then I'm going to backtrack one chapter and do the heart. It really doesn't matter which one of them come first, but it wasn't the order that your book went in. So I don't know if that threw you off, or maybe you thought I wasn't going to do the heart. No, definitely. These three chapters, cardiovascular, the three chapters of the cardiovascular system, if I only had one topic to talk about for this semester, then it would be this. It would be cardiovascular, if I can only pick one of these systems to teach. Because it's by far the most common one. So, hey, how are we with masks? How do you feel? Like, are you uncomfortable if I'm up there without one?
Yeah, you don't need it.
Really?
I'm good.
If we're far enough apart.
You good.
All right, I'm gonna keep it right here in case.
You good.
I don't wanna,
You good.
okay. I'm respectful of you. If there was like 3 or 4 of you in here, then I'm like, okay, let's do
You
it.
good.
Not that I don't wear it everywhere, I do.
I'm tired of wearing them.
I know, me too, but. Okay, so a couple things that I want to talk about. I'm just gonna write it down just for myself. What else? One more thing. All right, that's just for me. Some stuff I'm going to talk about. So we left off talking about how blood pressure drops. Oh yeah, that's another thing. We talked about how blood pressure goes down considerably from an artery to a vein. So the blood moves through the artery, then through arterial, then through capillaries. Yeah, let somebody in. Then through venules, and then veins. And by the time it gets to a vein, it goes from like 100 millimeters of mercury to like 10 or 15 millimeters of mercury. So now the veins going back up your legs and coming up your arms and everywhere have very low pressure. And your heart has to power that returning. So I'll just put, I don't know how. What I'm saying is, how do we get the blood back to the heart at the end, like at the end of this whole circulation, right? And so the first way is the heart itself, but that's a lot of work. So the ventricles need help. You can't have the ventricles do all the work themselves. I shouldn't say ventricles, really, because it's not ventricles, is it? It's one ventricle. You remember what side? What side is pumping blood all the way down your legs and all the way back? Left or right? I'm hoping you're saying left. So the left ventricle has to pump this blood all the way down and all the way back. That is a lot of work for a ventricle. So it needs help. So coming up your legs, we have something called the skeletal muscle pump. So here's like this is like a calf muscle, and here's like a vein, here's a vein going up there's a vein going up your leg, and then I guess in black, you've got these valves, your veins have valves. So those valves keep all the blood moving in one direction. So if the blood's going up your leg, if for some reason it can't quite get up there and it starts going backwards, those valves are going to shut and keep the blood from going back down to your feet. So every time you take a step, your calf muscles are squeezing that blood vessel and pushing blood up. And then when you lift your foot from that step and you relax your muscles, the valves keep the blood from flowing backwards. So that's what it is. Every time you're taking a step, your calf muscles are squeezing that blood vessel and helping to push up blood. That's the skeletal muscle pump. It's only in your legs. You don't have this really in your arms. Your arms are not as big of a deal. Because if you think about it, here's your heart, it's a shorter trip, especially for someone with my sized arms. It's a really short trip. Even with my legs, it's a short trip. So skeletal muscle pump. Another thing is called the respiratory pump. Actually, this is the only other thing I'm going to talk to you about. There are a couple of other small things that can help, but these are kind of like the big ones, right? So the skeletal muscle pump and then the respiratory pump. So if you look at the torso, so here's, my hands are running out. There's the legs, the arms. All right. Right here is your diaphragm, right? So your diaphragm's right underneath pretty much your sternum, and it's kind of like that, right? It's not flat. When your diaphragm's a muscle, and it kind of separates these two cavities, right? Thoracic cavity and your abdominal cavity. So it's kind of concave or convex, whatever it is. It's not flat. When it contracts, then it's flat. So every time you go to breathe, this diaphragm is going to contract. So it's not that you're breathing and your bigger lungs makes the diaphragm flatten out. It's not like that. It's the opposite. Your diaphragm flattens out first, and then your lungs get larger. But anyway, what happens when the diaphragm goes flat, when it contracts and it goes like that, it pushes all your guts. It's pushing all your guts onto so you've got like a vein coming up your leg, and then it meets in the middle here, and it goes up until it gets to your heart. Right, so this is the inferior vena cava. Oh, we haven't talked about that yet. So you got veins. All your veins are going to converge to a big vein. So when you look in the abdomen, there's a big vein coming right up the middle. Right, and so what happens is that when my diaphragm contracts, it pushes all my guts, stomach, liver, whatever, it pushes all of that, it makes it more crowded in there, and it pushes on this blood vessel. And that pushes the blood up towards the heart. So every time you're going to breathe in, That's the respiratory pump. When you go to breathe in, your flattening diaphragm, your contracting diaphragm, pushes all the stuff in your abdomen against, it's not like all the stuff, but it's putting pressure on that large vein, the vena cava, and that's pushing blood up towards the heart. Because when it's squeezing that vena cava, it's pressurizing it, right? It's just like if you squeeze a bottle of water, the pressure inside is going to go up. So that's some things that the ventricle's doing all the work, but these are helping. So you can imagine what somebody's screwed up heart is going to do to the veins. Like it's hard to get the blood back up when you have left-sided heart failure or you've got a jacked up left ventricle. It's hard to get that blood up, and it doesn't always make it up with these people. It doesn't get it back up to the heart. So some of that stuff is going to pull in the feet, and you're going to get, we call it like pedal edema, like it's going to start swelling. So we definitely didn't talk about the heart, right? No, we're still kind of new. All right, so that's that. And since we're on pressures, let me talk about what regular blood pressure is. So when we take a blood pressure like in your arm, you're really looking at the brachial artery, right? And you can take blood pressures different places. Like if it doesn't work here, you could take it in the forearm, right? You could take it in the leg. You got to make some maybe slight adjustments, but really in practice, no. I mean, if I take a blood pressure in the forearm, I'm not going to make an adjustment. I'm just going to take that blood pressure, right? It works. It works wherever it is, but most of the time we're trying to read the brachial artery. And a normal blood pressure, a number, just because we have to agree on a number. So kind of standard is 120 over 80. That's just a number, right? So blood pressures I never see them 120 over 80. It all depends. But it's somewhere in that range, 110 over 70. It can even go down to 60. It could go way up to, so anyway, you get my point. What are these measuring? First of all, this is 120 what? It's pressure, so what do we measure pressure in? You're thinking to yourself, millimeters of mercury, and you're absolutely right. So, this one we call, as you know, systolic, and this one we call diastolic. Diastole. So, these words, systole and diastole, or diastole, by the way, I might have told you this. If somebody calls it diastole or diastole, don't correct them. Don't correct people. This is like a good thing of it, like piece of advice. Don't correct anyone's pronunciation of like medical terms, because a lot of times there's more than one way, acceptable way to say one word. So you might look stupid if you correct somebody and it turns out like they were right. So anyway, so you have systolic and diastolic pressure, right? Systole means contraction, diastole means relaxation. So every time the heart, I keep talking about ventricles, huh? I'm so sorry. So when your heart contracts and pushes blood out, that's this higher number. So every time my heart beats and it contracts and it pushes blood out, that's the pressure on this artery. So this top number is pressure on artery wall during heart contraction. In particular, it's pressure on the arterial wall during ventricular contraction, but we got to talk about the heart. But I think some of you might have gotten it in A&P1. But anyway, every time my heart contracts, what's the pressure on this artery? This number, every time my heart relaxes, what's the pressure on this artery? That's it. That's what it means. So when the ventricles, when the bottom part of the heart is in systole contraction, what's the pressure? When it's relaxing, what's the pressure? That's all it is. And there's some other types of pressures you can get, like mean arterial pressure, things like that, right? And now they're saying that this 120/80, now they're saying that maybe is not an ideal blood pressure. So they always change it. So that's your blood pressure. Pressure on the arterial wall during contraction, pressure on the arterial wall during relaxation. And if we were coming on campus, we would do like manual blood pressures. So the blood pressure drops, right, as you go from arteries to arterioles to capillaries, venules, veins, the blood pressure goes down. That's because of resistance. So what resistance, meaning opposition to blood flow, something messing with the free flow of blood. There are a few things that influence resistance. The first thing that influences resistance is the lumen of the vessel, meaning how wide is it or how narrow is it. So, and a capillary is a lot smaller diameter, that's what I meant. The diameter as the diameter goes down, the pressure goes up. It's like exponential. So it's not, when I make the lumen half as small, the pressure goes up times 2. It's not like that. So if I make the lumen a half smaller, like I make the diameter half as small as it used to be, pressure goes up 16 times. So just making the vessel half as small makes the pressure inside that vessel go up 16 times. And it makes it slow down that much. Like it makes a huge difference. So going from an artery to an arterial already makes 16, 20, 30 times the amount of resistance. So as the blood vessels get smaller, resistance goes up. That's your takeaway. I know the camera's moving around. I'll try to stay still. 2, the total length of the blood vessel. And I gave you the example of, the textbook type of example is 1 kilogram of adipose equals about 400 kilometers of capillaries. So doing like a really rough conversion, and it's not even accurate, but it's somewhere, a pound. I was saying the other day, like a pound of fat, that's what adipose means. Pound of fat tissue, adipose tissue, is about 250 miles of 220 miles, right? A lot of extra capillaries. So the more vessels you have, the more resistance you have. And think about it, what happens when resistance goes up? Your heart has to work harder now. It has to work harder to push blood through your body. So, 3, viscosity. That means the thickness. So as your blood's thicker, there's more resistance. So those are 3 factors that influence resistance. Any questions? How are we with time? Oh, we're doing good. I don't know why I keep saying we. We're not doing good at all, are we? I'm doing good. I'm on schedule. So that's resistance. Okay, so let's talk about what happens when blood pressure goes down. We call that, well, commonly it's called shock. So shock or hypoperfusion is when you can't get enough oxygen to your cells. Your tissues need oxygen. You need to oxygenate your tissues. If you cannot do that, that's shock. That's essentially low blood pressure, like dangerously low blood pressure. So we've talked about some hormones that deal with blood pressure. Antidiuretic hormone, aldosterone, you could throw angiotensin 2 in there because it's a vasoconstrictor. Those things are to compensate against shock or hypoperfusion. Right, so hypoperfusion is shock. There's different types of shock. I'm going to talk about 4 types. There's other types too. I'm not going to discuss septic shock, although that is a type. So I'm just going to kind of keep it at 4. And the first type of shock is called hypo meaning like under, not enough, right? And then volume, hypovolemic. So not enough blood. And if you think about why you wouldn't have enough blood, you already know because we talked about that with the renin angiotensin thing. You're dehydrated. Or, I'll put another new word, hyponatremia. That's a good word you should know. NAT, natremia, when you see NAT, you think of, that kind of looks like an NAT. The sodium. So hyposodium, right? Not enough sodium. So hyponatremia can cause sodium deficiency. That can cause hypovolemia. Diuretics. Sometimes people take too much of the heart medication. That's going to cause too much water to go out. And that type of stuff is common, a doctor gives a medication, like as a diuretic, and then that person goes back to the doctor a few months later, and the doctor's like, oh, that diuretic's not working as good, I'm gonna put you on another diuretic, right? But they still have their bottle of the other diuretics, and you'll see a lot of people, they don't know what pills they're taking, they just put them all in the thing, and so now they're taking 2 diuretics. I mean, it's like things like that happen. Yeah, so diarrhea, that's a common, like getting some kind of like extreme food poisoning, taking diuretics, anyway. So hypovolemic, that's one. Another type is cardiogenic. Cardio meaning heart. Gen means like, the beginning, whereas the problem's beginning with the heart. So for example, a myocardial infarction, heart attack. See that? So a heart attack, something a bad heart, something that's interfering with the heart. Something can block the blood vessels, so it could be obstructive. And the typical example is a pulmonary embolism. It's one of the reasons. Pulmonary embolus, an embolus is like a mass of something. But really, an embolus, we're talking about a clot. So a blood clot, making a blood clot that shouldn't have been made, and it's floating around the body, and it gets stuck in the lungs, and now it's blocking capillaries in the lungs. So that can drop the blood pressure. So bad heart, you're blocking vessels, you don't have enough blood in you, and your blood vessels dilate inappropriately. So we call that, there's different names for it. Some people call it neurogenic, and some people call it, well, I just forgot the other word because I was just thinking of the word neurogenic. So I guess I'm going to put neurogenic. Vascular, whatever, neurogenic. I'll think of it in a minute. Inappropriate vasodilation. You might see through the semester, I might write this a few times. I might write dilation, D-I-A-L-A-T-I-O-N. It's completely wrong. If I write it, don't write it down. But it's just something that, like, I got it in my head one day the wrong way, and I can't stop writing it incorrectly. So anyway, inappropriate vasodilation. You're just like to make your blood pressure go up, you can constrict your blood vessels, like angiotensin does, or vasopressin, ADH. You constrict your blood vessels. Constrict your blood vessels, pressure goes up. Dilate your blood vessels, pressure goes down. Your body dilates blood vessels sometimes. Think about if a bee stings you in your hand, the blood vessels in your hand and your arm are going to dilate because your body wants to get stuff to that area. You're trying to get white blood cells to that area, like monocytes, for example. But anyway, you're trying to get stuff over there to take care of the bee venom. But some people that have allergies, your whole body acts like it got stung. So all your blood vessels dilate instead of just a localized reaction, right? So that's gonna put you in shock. killing me, I can't think of the other word. This is a totally acceptable, appropriate word, too. Hypovolemic, cardiogenic, obstructive, vascular, whatever. Okay. So, yeah, this is the peanut allergy one. What would you give for this, since I clued you with peanut allergy? You give epinephrine. Because this is a parasympathetic type of reaction. So you have to counter it with a sympathetic reaction, right? So this is going to be blood vessels dilating, bronchioles constricting. So with epinephrine constricts blood vessels, get pressure up, and it does the opposite with your throat. It dilates it's a bronchodilator. It dilates your throat. Because if you think about a fight or flight response, fight or flight, I want more oxygen to get into me because I'm trying to make ATP. We didn't talk about that, but that's what happens. You're trying to get a lot of ATP to your muscles, but I need to make it. So I'm going to break up fat, I'm going to break up sugar, but besides that, you need oxygen. So I need to breathe, I need more. I need to increase my breathing speed, my respiratory rate, and I need to dilate my vessels, my bronchioles. So this is 4 different types of shock. It's not exhaustive here. There's other types of shock. These tend to have similar symptoms, which is why I put them together. Septic shock tends to act a little bit differently. But a symptom of this type of shock would be blood pressure. So a normal blood pressure is like, let's just say 120/80, right? And so then if I see a blood pressure that is like 80/60, right? The numbers are down, right? So obviously the pressure's down, but there's not a difference of 40, right? The 120/80, there's a difference of 40. Here, that difference is narrowed. It's more like 20 here, right? So when I see those numbers get closer together, that's like another sign of shock. So lower numbers, they're closer together. And if you look at the heart rate, that's going up, right? Because your heart's trying to compensate. And there's some other things, but anyway, those are 4 types of shock. What can your body do to control low blood pressure? What can your body do to control shock? Well, I'm going to erase this now. So what can it do? Well, we talked about it actually. You already know the answer. You just think about like the hormone, for example. It's the same type of thing. So, step 1, the easiest thing to do. And forget about the hormones here, because the hormones aren't initially doing it. I mean, they will. The hormones are also going to do it, but your brain is doing it. There's 2 responses. There's a neurological response. Your brain's going to do something. Then the chemicals. Just like fight or flight. Right? I was talking about a snake or something like that. You're not going to wait for epinephrine. You're going to move. You don't have 2 seconds. Right? So your brain first is doing it. Then your body follows up with chemicals. Same thing with shock. Your brain's going to move, and you'll follow it up with chemicals. Your body is redundant. It has redundancies built into it. So if one way doesn't work, it's got a second way, and it's got like a third way. So you've got backup systems built into your body. Constrict your blood vessels. So all your blood, most of your blood vessels, not all, but your arteries, your arterioles, they are lined with muscle. Remember the muscularis layer. So they're lined with smooth muscle. So your brain is going to contract that. So that's going to use the vagus nerve. Remember those cranial nerves? I bet you had to learn them all 12, huh? Remember what number this one is? CN, cranial nerve. So 10th cranial nerve. If you remember anything about the cranial nerves, you have 12 of them. They all go to about here, your upper shoulders, right? The accessory nerve, I think, goes here. But the 10th cranial nerve is the only one of the 12 that go further down. So for us, when I talk about something with the heart or blood vessels or digestive system, we're talking about cranial nerve 10. So whatever one you want to say, right? They're both the same thing. But that's tied into your arteries and arterioles. So that's a sympathetic response. So we're going to constrict those. These same nerves are also plugged into your heart. So you want to increase your heart rate. That's going to be a compensation. So that's something your brain can do right away. And you have receptors that are they're around your body, but they're in two particular places. You have receptors in your carotids. I'm just going to put neck, because the carotid arteries are in your, you should know now what these are, because from the lab. They're in your carotids, they're in your neck, and your aorta, which is like the biggest, I'm just going to write it down. So in your aorta and your carotids, you have these receptors. They're like sensors. They're sensing what's going on with your body. And you have different types of receptors, but some of them are called baroreceptors. I'm going to get a new pen for next class. You have baro meaning pressure. Pressure receptors. They're pressure sensors. They're sensing your pressure. They're mainly here. And that's wired up to your brain, to the brain stem actually. It's wired up to your medulla oblongata. So on one end, you've got these receptors around here, and they're sensing the pressure, and it's wired up here, and then you've got another wire running down to all your blood vessels, your vagus nerve. Right, so you've got nerves running from these receptors up to your cardiovascular center, and then you've got other ones running back down to the vagus nerve and to your heart. I mean, through the vagus nerve, they run to your heart and they run to your blood vessels. So constrict your blood vessels, increase your heart rate. That's your cardiovascular. That's your neurological response to shock. But there's chemicals. There's a chemical response to shock too. The chemical response to shock is through hormones. And if you think about it long enough, you know what the hormones are, because you already know them. Oh, fucking pens. Epinephrine and norepinephrine. Norepinephrine is going to increase like the strength that your heart contracts. Epinephrine is going to make it beat faster. Norepinephrine is going to make it beat stronger. That's going to help a little bit with blood pressure. And epinephrine is going to it's gonna be like a vasoconstrictor, that's gonna help with blood pressure. And then we have our friend ADH, antidiuretic hormone. Don't use water in the urine. Also constrict blood vessels. So that's, this, you see that this is not like immediate, right? Don't make as much, don't put as much water in your urine. That's very important, but it's not for the next 10 seconds of my life, right? It's for the next 10 minutes, but, these are chemicals, but they come in a little bit later, and they're gonna last for longer. So ADH, you know what ADH does? It's gonna make you produce less sweat, less urine. It's gonna make your, and it's a vasoconstrictor. And then you have, which works even better as a vasoconstrictor, angiotensin II. That's a vasoconstrictor. And then we could say aldosterone. The whole renin, angiotensin, aldosterone process, right? That's gonna start happening. I shouldn't say it's gonna start happening. It's not like you go into shock and then this happens. This has already been going on. Like by the time you're in shock, this is already going, right? But it's kind of keeping you I'm just looking on my phone to make sure none of you are texting me. I'm always afraid of my sound going out. So this is the chemical side of it. Your body's response to shock. So it's compensated. When they talk about shock, they have this notion of compensated shock, right? You're in shock, but your body's compensating for it. And so when you look at people, you can see them slowly going down, right? Because initially, this stuff's kind of working, but then as you follow them through time, it's not working as well. So you're gonna see blood pressure like keeps going down, and you can just tell. Younger people, little kids, they're excellent at this, right? So they could be going into shock, and they can keep it up for a long time. They're riding normal, and then all of a sudden, bam, they're out. The adults, you can kind of see them slowly going. So that's it. That's the body's response to shock. So let me sum up all the things that we talked about, or more importantly for you, all the things that I want to test questions about. Any questions on this? Let me see if my blue works. Green. I guess you can see green. Hey, let me ask you something before I write these questions down. Somebody unmute themselves and tell me which one works the best.
Black.
It's just you and me.
Black.
Which one?
Black.
Black. All right, so we're still on black. Okay. What's the difference between distributing and conducting arteries? Or the other name, which gives you the answer, what's the difference between, which one's this? It's either muscular or it's elastic. 50-50 shot. Are you thinking elastic? Because that's wrong. Muscular, distributing arteries are muscular arteries. Conducting arteries are elastic arteries. And this one's like an easy question, so just like a sentence. distributing or muscular arteries are further away from the heart and they're able to constrict. These are closer to the heart and they're able to like stretch out. What are the three? Describe, here's how I would ask you, describe the three types of capillaries. So you just say conducting. You say continuous capillaries. You would talk about like how they only have the intracellular cleft, so not a lot of movement in and out of those capillaries. Then you're going to talk about fenestrated capillaries, how they have their intercellular clefts are a little bit larger, and they have fenestrations, aka pores. Sinusoid arteries, capillaries. Sinusoid capillaries have very large. So you take what you put for fenestrated, and you just say very large. That's your only change. So very large intercellular clefts, very large fenestrations. And that's all it is. So just take whatever you put for fenestration and just say very big, huge. The likes of which nobody has seen before. I don't get to say that for much longer. 3. Let's go into stuff we talked about today. Factors, I guess, resistance. Factors contributing to resistance. Contributing. Three factors contributing to the opposition of blood flow. The lumen, what does that mean? Don't just put lumen. I want to know that you know what that means. What, a smaller lumen, a bigger lumen? What does decreased lumen mean, right? So you're saying it's a smaller diameter. That's going to make more resistance. More blood vessels mean more resistance. And 3, viscosity. That's the thickness. As the thickness of the blood goes up, the resistance goes up. Oh, now I'm thinking of the one from last class. 4, what are the pressures driving filtration and reabsorption? There was one pressure that we talked about, no, 2 pressures driving filtration. There was the blood hydrostatic pressure. I want you to explain what they are. Don't just put BHP. That is 3 letters. That's all that means to me. That doesn't mean you understand it. What is blood hydrostatic pressure? It's the pressure from your heart beating. That's good enough. The pressure from your heartbeat. That tells me you understand what it means. Then the other one for filtration was interstitial fluid osmotic pressure. So you've got more albumin in the interstitial fluid. That's pulling the water out. Water follows albumin. Reabsorption, blood colloid osmotic pressure. That's more interstitial fluid in the blood. That pulls water into the blood. That's reabsorption. Shock, we just talked about it. What are the 4 types of shock? Don't just put MIPE. Again, and you may very well know what MI means. Like, I get it. Like, you know what, you obviously know that I know what it means, right? But it's not about that. I want to know that you're understanding that the heart's not working. You can put that. That means that MI, the heart's not working. Or you can put heart attack. The heart's not working for some reason. Stuff like that, right? Don't just put PE. What does that mean? Oh, there's an embolus in your lungs. It's blocking. Responses to shock. Responses to responses to hyperperfusion. When you address this question, number 6, how does the body respond to shock? I'm really asking you, how does the body control blood pressure? So, there's 2 things here to consider. 1, a neurological response. What's your brain doing about it? 2, what is the endocrine system doing about it? So you've got the brain and you've got chemicals, so make sure you do both. So I guess you could start with either one, but as far as like the brain, you have receptors. And I only talked about one, so that's fine. You have baroreceptors. They're monitoring blood pressure, right? And they're found in your carotids, your aortic body, and that's going to stimulate a sympathetic response. The vagus nerve. So say that the vagus nerve is it innervates your arteries and arterioles. So that's going to cause vasoconstriction. So the neurological response, vasoconstriction through the vagus nerve, the sympathetic response, increased heart rate through the vagus nerve, through the sympathetic response. That's neurological. Talk about the baroreceptors. That would be a nice little add-on. Then you have chemicals. ADH, talk about what that does. Angiotensin II, talk about what that does. Aldosterone, talk about what that does. Epinephrine, talk about what that does. So it's 6 questions that I got from that chapter. So the exams on these, I'm thinking right now I'm going to put all 6 on. I might combine 5 and 6, but I'm putting all this on. And then I'm going to add questions from blood. I can tell you now, I'm not going to ask the question about red blood cells again. The fate of hemoglobin of red blood cells, because I already asked that like 3 times, I think. So definitely not asking that. But, the other questions that you have down from quiz number 2. I might change the wording, I might keep it the same. I tend to be lazy, I might just keep it the same. I don't know. But, so you got your questions from quiz 2. I've got these questions. I've got videos that I made on this. There's 2 videos. If you go on pages, I have to go to modules and make sure it's on there too. But, yeah, it's called, I don't know, it's whatever. It's called I think blood vessels part 1, blood vessel physiology part 1, part 2. So you can find all of this. This is all going on quiz. And I'm not even gonna, I was gonna start going into the heart today. I'm gonna wait. So, exam 2. You know your questions, these questions, and the questions that you have in the test bank about blood. So it's going to be blood and blood vessels. That's exam 2. Do you have any questions on any of these? Y'all got to study. Not you all. Some of you have to study. There's no reason not to get 100. There's no way around. Your back's against the wall. There's no multiple choice questions. You're going to be in here. I'm going to be watching you. There's like no way around it. Just you have to learn it. But you know what it is. So it's really all about time. It's not like I'm surprising you. So you just got to spend the time with it and get it in your head. If you understand it in your head, it's going to be,